Diagnosis and management of neurocognitive disorders. Her work at the Roskamp Institute Clinic is aimed at early recognition and accurate diagnosis of memory disorders with the goal of timely treatment and recruitment for clinical trial research as appropriate. Dr. Brandi has 10 years of experience as a nurse practitioner and over 30 years as a nurse. She's held nursing faculty appointments in several academic settings, conducted nursing research, and is also a retired Navy Nurse Corps commander with over 23 years of continuous active duty service. And we thank you for that. 23 years. She holds a postmaster certificate as a nurse practitioner, a doctorate in nursing, a master's degree in nursing, and a master's degree in human resource management. Ladies and gentlemen, this speaker has many talents, but her passion is bringing the exciting work of the Roskamp Institute out to the community. Please join me in welcoming Dr. Cheryl Brandi.
I want to start by talking a little bit about the Roskamp Institute because this is not so well known sometimes in our community, although it's internationally known and nationally known. And thanks to the work of the philanthropists Diane and Bob Roskamp, we have the Institute, and under our founders, Dr. Mike Mullen and Dr. Fiona Crawford. So the Roskamp Institute, just in a nutshell, is a not-for-profit biomedical research institute and clinic. There are over 60 staff, including PhD scientists, clinicians such as myself, and the physicians who work there. PhD students, so it has its own university, research associates, technicians, and all those people, staff and consultants who really help to keep things going. The research basically targets neurological and neuropsychiatric diseases, basically with the goal of treating and curing diseases of the mind. And the funding is numerous: National Institutes of Health, Veterans Administration, Department of Defense, Alzheimer's Association, Roskamp Foundation, etc. The Roskamp Institute programs consist of Roskamp Laboratories, Archer Pharmaceuticals, and I'm going to talk a little more about Novatapine in a little bit. SRQ Biocontract Research, and then on the other side of the house we have the Roskamp Clinic, where I'm affiliated, and we're basically a full-service ambulatory neurology clinic. Many people don't know that. And we also do clinical trials, and I'm going to talk a little more about that. Not only in memory and Alzheimer's realm, but we also have clinical trials for multiple sclerosis, migraine. We recently had one on Parkinson's. We've done some on nutraceuticals, and many people don't realize that. We do have a table here today, so if you have questions about that, there are people who can even explain this more better than myself. So, in talking about brain health, and I'm going to talk about dementia. I don't like the word dementia. I didn't coin it. I wish it would go away. We'd have another word for it, but that's what we have. And when you look at the research that's being done, it's really taking off, but we're really just at the tip of the iceberg. We have a long way to go to raise this iceberg out of the sea. So I want to put a pitch in for what should I believe, because I don't know about anyone here, but I get 3 or 4 emails a day of some latest research. I open AARP magazine and there's something about brain research. I open Time magazine and there's something about Alzheimer's research. I open my military journals and there's something about research, and I'm sure probably the National Enquirer has something about research, which I don't read. But that brings me to my point, in that in the TV ads are abundant, and there's a lot of opportunity for exploitation also in this realm. So, I mean, I think if the science is good, the scientists have presented and they published in reputable journals, the sample size is healthy, it's robust, maybe more than one site has been involved. And so if you're not sure, ask the questions. Never stop asking the questions. That's the key. But also be a little bit skeptical of everything that you hear and read. So I'm going to talk about the continuum of neurocognitive disease research, and I'm working backwards purposely because, again, I agree, and you're going to hear this throughout this, symposium, that we're moving towards prevention, risk factor identification, and that's really key, and that's really why you're here today. But I'm going to start with the treatment of disease and finding a cure, and then we'll work upstream from that. So we need to move into more from downstream thinking to upstream thinking in terms of these conditions. So what is the current state of science? Well, let's talk about treatment of disease, finding a cure. And I'm going to use Alzheimer's in particular because that's the one that we know the most about. Actually, this week and next week is the big Alzheimer's convention, the International Convention in Toronto. So stay tuned. We might be hearing some more very soon. But currently, there are only 5 FDA-approved drugs. 4 drugs came to market between 1996 and 2003. And the last drug was approved in 2014, but it's a combination of 2 older drugs. So to date, we have no approved drugs to work at the disease targets. Diseases targets such as protein buildup of amyloid and tau proteins. And so in brain tissue, when we talk about amyloid plaques in brain tissue, this is just an example, greatly magnified, of plaques and how they destroy brain tissue. And I probably will mention this again, but these plaques can be building up in our brains 10 to 15 years before anybody has any signs and symptoms. And we know that from autopsy research. So why has drug development been so slow? Number 1, stigma and denial. We need to destigmatize the idea that having an issue with mind or memory that's a little bit more advanced than where it should be for age is something that should be hushed up or covered up. And when we move to that, I think we'll be getting some more better participation in our research. Money is another issue, and lack of volunteers needed for clinical trials. So let's talk about money for a minute. Federal funding in 2015, $5.4 billion went to cancer, $1.2 billion to heart disease, $3 billion to HIV/AIDS. And I'm not saying that this is a bad distribution, but look where Alzheimer's disease sits in this. And for one of the issues that is the most expensive medical issue in our society, there's something wrong with this picture, I think. Another issue is the lack of volunteers. We really need about 70,000 volunteers urgently for 150 clinical trials. This is from 2015, so I'm sure it's even more so. But clinical trials and research studies related to Alzheimer's disease. So recruitment for these studies is really, really important. I'm going to talk about one type of clinical research. There are many different types, but I'm most familiar with clinical trials, and they do offer hope for our future. Clinical trials are a way to learn if a treatment is effective and safe. Most involve drugs and a placebo or a dummy pill. And I will tell you that if anybody has any hesitation about being involved in one of these situations, there are such strict laws that govern the way clinical trials are conducted. At our institute, we have 3 clinical trials coordinators and a clinical trials site manager and several other people, and their sole task is working and managing and recruiting and monitoring for these clinical trials. It's very tightly regulated. There are some promising advances in Alzheimer's disease treatment. We are working on experimental drugs, not we, I guess the Institute is, that target specific disease proteins such as beta amyloid, tau, and beta secretase, which is an enzyme that results in the buildup of beta amyloid. And we do have trials going on in those areas at the Roskamp Institute right now. And so if you're interested in more information, again, the clinical trials table here is a good place to check. There's also, this is exciting because we're learning about different uses for older drugs, and nilvatapine in particular. This is an encouraging Roskamp Institute trial that's being conducted in Europe, known as the Nilvad, if anybody is interested in pursuing it. And nilvatapine is an older drug. It's a blood pressure medication that's been used in Europe. If anybody wants the particular details, it's a calcium channel blocker, kind of similar to some that we use, and as I understand, really hasn't been that effective in blood pressure control. But nilvatapine in animal studies was shown to block production of amyloid and increase cortical brain circulation in animal models. And that research came out of the Roskamp Institute. Phase 3 trials right now, it's very difficult to get to a phase 3 trial and near completion in this type of research endeavors, but phase 3 trials are nearing completion from 9 sites throughout Europe right now, and I believe October of this year is when they will close the phase 3 data collection. That's very, very hopeful, because if the information at this point is promising, data have to be analyzed, so they still have to go through this whole process of analysis, but maybe we'll be able to get something, to get some FDA approval to have another way of dealing with Alzheimer's disease. So stay tuned, and if this comes to fruition, there will probably be some fireworks over Whitfield Avenue. So, moving on to earlier and more accurate diagnosing. So we don't have a cure. We don't have a treatment per se. We have Band-Aids that we can put on things. But there is a lot of interest in new imaging techniques, and ability to see amyloid buildup on an MRI, on an imaging of an X-ray to aid in diagnosis. You know, we can't get into people's brains. You know, we can't split open the head and look and see what's going on. So we have to look at, can we do something in a more non-invasive way that gives us a better picture? And so we are participating in an IDEAS trial in partnership with some of the local radiology organizations. And the idea with this is to be able to, well, the technology is there to be able to see amyloid on imaging. Right now it's being used to distinguish between amyloid that would give us an idea that this is truly an Alzheimer's picture versus another type of disease process, and does it make a difference in the way that we treat people, and will it make a difference in recruitment for clinical trials? So I would stay tuned on this, because I understand they're also, tau is also being, is in the process of being able to be imaged also. And somebody's going to ask me what IDEAS stands for, and I will tell you that later. I have it written down, I can't remember. We're also moving to a better understanding of mild cognitive impairment. There is an international working group on this topic. There are a number of symposiums that happen annually. And it's an issue because can we develop better screening tools to understand when someone is kind of slipping off that curve, so to speak? Or why do some people have mild cognitive impairment and they continue just at mild cognitive impairment? They never get worse. Or what about the person who says, I know all of my studies are normal, I know everything you've done is normal, but there's something that's not right. And remember, those amyloid plaques can be building in the brain 10 to 15 years before they can become apparent to those around as a symptom or a sign or symptom to those around us. So there's a lot of interest in this from the basic science as well as the clinical science, and a lot of, shall we say, discussion in terms of what mild cognitive impairment really is. Biomarker validation is also of great interest. We can do a blood test and say you have diabetes. We can do a blood test and say you have high cholesterol, but we don't have a blood test that says you're having a change in your cognitive ability and now it's time to get some help. So that's another interest for research. We do have a current study, a small one, that is actually Dr. Keegan's personal study at the Roskamp Institute, and if the funding continues for it, we will continue it. But it's basically having healthy volunteers go through a memory screen process, taking a blood sample at that point, and then following them out over time annually, with the idea that if there is a change in their thinking or memory that slips off that curve, we would be able to go back, or someone would be able to go back and look at those blood samples to determine was there something in there, was a particular biomarker. All right, so we know we don't have a cure and much of a treatment. We have Band-Aids. We know we're trying to work at earlier detection, knowing that earlier detection leads to earlier treatment and management and planning and all of the other issues that go on. But in the absence of disease-modifying treatments, risk reduction takes on a new meaning. And again, you wouldn't be here if you weren't interested in this. And some of what I'm going to say next is something that you just heard from Dr. Grindal. I'm going to just present it in terms of how the research supports it. So even with new treatments, risk reduction will be a basic strategy, and we're coming to believe that even Alzheimer's and Alzheimer's treatment is probably going to be a multifactorial or a multi-treatment type of situation, much like even, I think, like diabetes is right now, where you come from a number of different directions as we understand the pathophysiology a little bit better. And clinical studies are limited regarding specific interventions. There have been a couple of studies, one done in Europe, the Finger study, that does look at the effectiveness of certain lifestyle treatments. And I think you're going to hear more from the other speakers and more this afternoon on some of this type of research. But the evidence is sufficient to support modifiable risk factors. So the Alzheimer's Association took a lot of studies and a lot of epidemiology work and kind of collapsed it, did meta-analyses to get some strength of recommendations for what people can do in a preventive aspect in their life. So, risk factors, all right. You cannot change your age, family history, and genetic susceptibility. Well, those are big risk factors. But this cartoon says, I smile because you're my family. I laugh because there's nothing you can do about it. I have a couple of those in my family. So, you know, that it is what it is for that part of it. But there is sufficient evidence to support associations or linkages as a research team between modifiable risk factors and reduction for risk in mild cognitive impairment and dementia. And basically, and I think you just heard this, heart health is brain health. So we always think about the things we do that are good for our heart, and we haven't really thought about how those translate to brain health also. So, cardiovascular risk factors for cognitive decline. Again, you just heard this, diabetes, and there is strong evidence on increased risk of dementia in people with diabetes. So that is really a critical. We think of diabetes as impacting our kidneys, is impacting our heart, as a stroke risk, as a loss of limb risk. But we don't think of it in terms of a dementia risk factor too, which makes it even more and more imperative to have good treatments for diabetes and get it under control. Midlife obesity, there's strong evidence for an increased risk of dementia with people with midlife obesity, and midlife hypertension, strong evidence for an increased risk of mild cognitive impairment in that group. It changes a little bit with more the seniority process, because sometimes we like to keep that blood pressure up there just a little bit more for, you know, perfusion of the brain. But the midlife is really the key point in this. So lifestyle factors that reduce risk. I shouldn't even have to talk about smoking, but it is the number, it is up there, and it's really linked with dementia also. Physical activity, you've heard this already, you're probably going to hear it again. Even mild activity is linked to a decreased risk of cognitive impairment. And diet, you just heard this also, combined Mediterranean DASH diet has the best evidence among diets for reducing risks of cognitive decline and dementia. And other risk factors, we've talked about education. So we know that the more education that you have, the less risk of developing dementia as part of this meta-analysis. And I guess that brings up the point, because in terms of education, you know, this is Sarasota. We have the Lifelong Learning Institute, we have our universities, we have the technical colleges. I mean, we have so many opportunities here to keep our brains engaged with the libraries. And in terms of physical activity, we live in a place where there's absolutely no reason for someone not to be able to get out even and walk much of the time. I mean, we're just very fortunate. So it's probably easier to reduce risk here than in many other places, I think. We know that traumatic brain injury, there's solid evidence to link brain injury to an increased risk of dementia. So the take-home message here is in terms of wear your helmet when you're out on your bicycle or on your motorcycle. And falls risk, you know, look at your homes from a safety perspective with your bars in the shower. I certainly have them in mind, because if something happens, I'm going to go down hanging on them, I will tell you. History of depression, there is a moderate link to an increased risk of cognitive decline in people with moods we're finding are more and more important in terms of dementia and mild cognitive impairment prevention. Sleep, you've already heard. Sleep, particularly sleep apnea. Sometimes people sit in front of me and they say, I didn't know my sleep apnea, you know, could contribute to this. And it really does. The brain does not like having periods where it doesn't get oxygen at night. So there is a huge risk. And I'm just going to mention caregivers of family members with dementia. It's a whole nother realm to get into, but we do know that there is literature to support that caregivers of people with dementia progress faster into dementia themselves. And I know there are a number of research institutes, including USF, that is looking at that in particular. And believe me, from what I see, the caregivers in these situations are true heroes and heroines in working in these conditions. So, with that being said, research regarding neurocognitive diseases is promising, so stay tuned from the Alzheimer's Convention, the international that's been finishing up next week. So it's promising, but there's a long way to go. And you can reduce your risk now. And again, you're probably going to hear the same things over and over and over again. So there are a number of key take-home points with that. So to finish this up, and in conclusion, with the idea of mood related to good brain health, I hope you always find a reason to smile every day in all of your activities. And if anyone needs further information, that's who we are and where we're at. Thank you.